and Link Senior, as we're going to be discussing the resident engagement and rules of participation with our host, Mary Chiles. Before we get started, I just want to go over a couple housekeeping details. If you do have any questions throughout the entire presentation, please feel free to chat them into the chat box. You should see that option. We are going to keep everybody on mute throughout the presentation just so that we can eliminate any background noise. You should have gotten a copy of the presentation ahead of time, but if you did not, please feel free to download it under the handout section. And then lastly, one quick change. Unfortunately, or not unfortunately, excitingly, Charles DeVille-Morin, who is our CEO and co-founder, who was supposed to present with Mary, actually recently had a baby earlier last week. So standing in for Charles is going to be our colleague, Megan McMahon. So lastly, before we get started, at the end of the presentation, of course, to receive the CEU credits, if you could please take the survey that will be sent out. It will be sent both to your email as a follow-up, but I will also put the survey in the chat box at the end of the presentation. Other than that, we will go ahead and get started, and we will move forward here in just 1 second. All right, thank you, everybody. So as I mentioned, our hosts today are going to be Megan McMahon, who is the director of MBM Consulting, and she is also a former project manager for the Greenhouse Project, as well as the National PACE Association. We also have Mary Chiles, who is joining us and is the president and owner of Chiles Healthcare Consulting. She is a registered nurse, graduated from Richmond Memorial Hospital, and she is the co-author and co-founder of the Virginia Medicaid Specialized Care Program. On the agenda today, what we're going to be touching on is what do the rules of participation mean for resident engagement? How can existing technology help satisfy the new requirements? And of course, at the end, we'll wrap up with Q&A. Throughout the presentation, participants will be able to explore the new certification regulations for expectations and guidance regarding resident engagement, explore integration. A person-centered engagement can enhance quality of life and quality of care beyond just activities, and examine some core consequences to the residents and the organization when resident engagement is not meaningful. Now I'm going to turn it over to Mary, who will get us started here.
Well, thank you so much for allowing me to be a part of this presentation today. As we review and think back over the past couple of years, we have seen a continued focus and emphasis by the Centers for Medicare and Medicaid on improving the quality of life for residents in our nursing facilities. When the MEGA rule came out and became effective last November, or November of 2016, and we began to read through the multiplicity of the regulations, we saw a common connection. There has begun to be a shift, while it's still important, but a shift from a focus on clinical issues, quality of care, to have equal emphasis and focus on quality of life for our residents. So when we look at section 483.24, quality of life, The intent of this requirement per CMS is to ensure that facilities create and sustain an environment that humanizes and individualizes each resident's quality of life. Now, they give us lots of guidance as to how we can go about doing that, but I want you to pay close attention to the verbiage of their intent. To create and sustain an environment that humanizes and individualizes. Humanizes gives us a different emotional response rather than simply individualizing something. It means that whatever we are doing takes an approach of value and a sense of worth. It makes that resident feel as though they are part of a community. When we look at some of the additional guidance from CMS, it wants to emphasize that this approach, this environment should become embedded and part of our daily life across all shifts in all departments. It's not just delegated to the activity department, not just delegated to social work or nurses, but to everybody and that works and is involved in that particular community, all shifts and all departments. What we want to do is to ensure that the care and services that we provide are person-centered. And that means that we create a balance between what is clinically needed and how we can make those services have meaning and value and hopefully positive outcomes for our residents. It means that we transition from a traditional model to actually thinking about the resident and their representatives as partners in care decisions, meaning that we take time to learn and respect and honor their preferences, their choices, their values, and their beliefs. So Sean or Megan, if we can go to the next slide. There are a couple of key definitions that I want to make sure that everybody understands. So the first key definition is the CMS definition of person-centered care, because quite frankly, I believe that each one of us may interpret that a little bit differently. But for the purpose of this particular subpart of the regulations, CMS says that person-centered care means that we focus on the resident as the locus of control, and that we, the team, assisting to provide services and care to that resident, support the resident in making their own choices and having control over their daily lives. Now, other regulations extend this very same aspect of participation and decision-making involvement to the resident's representative where appropriate. Another key definition that CMS put out was pervasive. And I think that it really has some applicability here. And again, for the purpose of this section of the guidelines, pervasive means that it's spread throughout or embedded within every part of something. So it means it's not just something that is scheduled. It's a way of life. It's a way of consistent approach to that resident and to that resident's representative. So let's delve down for just a few minutes and look at the definition of quality of life. According to CMS, again, it is a sense of well-being. It is a level of satisfaction with life and a feeling of self-worth and self-esteem. So let's pause there for just a moment, because when we talk about feelings, we have to recognize that different residents are going to have different perspectives. So it means that we have to be able to drill down and really be able to evaluate what that means to a particular resident or to that resident's representative. It goes on to say that for nursing home residents, this may involve a basic sense of satisfaction with oneself, meaning that the resident begins to feel good about themselves as a person. Oftentimes they're not able to articulate that, but we can see it through actions and behaviors. It means that the environment, the care that's received, the accomplishments of desired goals, and control over one's life. All of these things are important to you and I, and all of these things continue to be important to each resident once they move into the nursing home. And even though we have many residents who have impaired cognition, on basic levels, each resident still is able to feel and have some perception. So if we could go to the next slide that talks about principles of quality of life, we look at a 1986 Institute of Medicine report. Now, think about how many years ago that was. But at that point, they were emphasizing and defining what quality of life means. And it's still valuable to each and every one of us today. What was important then is important now. How we approach it, how we ensure that that becomes a way of life for our residents is what is different. So according to this report, quality of life includes things such as a sense of well-being, a satisfaction with life. It doesn't mean I have to be happy every day, but a general satisfaction with life, a feeling that the resident has some self-worth and that there is positive self-esteem. They go on to talk about a sense of satisfaction with oneself, a sense of satisfaction with the environment in which they live. It may not be their first choice, but are they comfortable? Do they feel safe? A sense of satisfaction with the care that they are receiving and that care is consistent with their choices, their decisions, their values, their culture. And perhaps most important, a sense of value in the fact that they were a participant and had some level of control over their life in the nursing home. So let's go to the next slide, because I think that this is a very important slide for us. Engagement is more than activity. This Institute of Medicine report went on to include some other key elements, and one was the importance of person control over their choices. And some basic choices, the things that we often inadvertently take away for the convenience of our staff. A choice of when I can have my meal, a choice of activities. Doesn't just mean that we have a variety of activities that are posted on an activity calendar for the month, but that I can choose what I want to do. Or quite frankly, I can choose what I don't want to do and explore other items. Looking at basic care, such as I can choose the clothing that I want to wear when I want to go to bed, who visits, what treatments, and so forth. Looking at my ability to participate in religious or civic or political activities that are of my choice and my interest. So when we look at the regulatory requirements, we find that quality of life is an overreaching principle that must apply to all care and services that are provided to the residents. So let's dig down, move to the next slide that talks about F-tag 679. This is the tag, the new tag with the mega rule that is about activity. And again, let's take just a minute to review the intent of this regulation. So it says that the facilities must implement an ongoing resident-centered activity program that incorporates the residents' interests, hobbies, cultural preferences, what is important to maintaining and or improving the resident's physical, mental, psychosocial well-being and independence. We've heard that for a long time. The key word that I want you to focus and hear me talk about today is that part of the intent of this regulation is to create opportunities for each resident to have a meaningful life by supporting and their domains of wellness. And what I mean by that is their sense of feeling of security, their sense of autonomy, their opportunity for growth, a sense of feeling connected to a community, a sense of value, a sense of identity, a sense of joy, and that this has some meaning, some importance to this resident. So we're going to focus today a lot on the word meaningful. Now, as we go to the next slide, we see that CMS has also provided us with a definition of activities. And again, just a quick review, but a couple of focus words. Activities refers to any endeavor other than routine ADLs in which the resident participates and that is intended to enhance that resident's sense of well-being and worth, or to promote or enhance physical, cognitive, or emotional health. So that gives us a much broader perspective. Again, it is not just a scheduled activity. It is oftentimes embedded in the way that we approach and interact with the residents. We certainly want to hopefully have activities that are meaning, that promote a feeling of self-worth and self-esteem for that resident, that create a sense of pleasure or an enjoyment. But they go on to say that it could be an activity that promotes a sense of comfort, and not just comfort in terms of comfort that relates to pain, but comfort in how we feel. So think just about a moment when you go to a new environment. Do you feel comfortable? Oftentimes we don't, and for a whole variety of reasons. It doesn't necessarily mean that there's anything wrong with that environment, but we can have a sense of discomfort simply by hearing things, simply by the way that something is arranged, the environment as a whole, if it's something that is out of norm for that resident. We certainly want to look at education, creativity, success, and we definitely want to create an environment of independence as much as we possibly can. And that will be one of the focuses today as we go through and looking at how technology can help residents be more independent and allow us to provide opportunities for them to participate in meaningful engagement of activities that is personal to them. So let's go to the next page, which does talk about meaningful activities, and they should reflect that person's interests, their lifestyle. It should be something that is enjoyable by the resident, something that will help that person to feel useful or create a sense of belonging to that environment or to that structure. So I want to spend a few minutes looking at fact, opportunity, and challenges, which is the next slide. So when we examine fact about these regulations, the fact is that these regulations are applicable to all of the residents in your facility. So let's stop and think about that for just a moment, because each facility has unique populations. Within the populations of that facility, there are unique individuals, and every resident comes with a history. Every resident comes with varied needs in terms of what they need for assistance, what they need for care, with their abilities or their limitations. Each resident comes with a different sense of expectations. We all have our individual choices, and much of that is based upon our culture, our past experiences, our ethnic values, and so forth. In today's environment, we have such a variety of residents in our building. We tend to categorize them sometimes. We tend to categorize them to our short stay residents, our long stay residents, our residents who reside on a dementia care unit or who have cognitive impairment, but it really goes a lot deeper into that. So we want to examine how within your organization can you create that environment across all shifts and all departments that really focuses in on an individual resident. We want to look at opportunity. And one of the ways that we can expand is to look at how we can integrate meaningful activities into daily life for each resident. Meaning that it goes way beyond the activity director or way beyond the volunteer, but how each individual staff member, volunteer, consultant comes into your building and interacts with your residents. We want to create methodologies and systems that recognize and support the value of such an approach and are able to be carried out in every aspect of care. We want to de-dramatize roles and responsibilities of staff. We want to look at how we can become defragmentized and approach things from an interdisciplinary entire team perspective, including involvement with the resident and or the resident's representative or other support people for that particular resident. Now, that doesn't necessarily come easy. In fact, it comes with many challenges. So we want to explore some of those challenges and how we can begin to break down the barriers to them. Some of the more common barriers that we see is getting the team engaged, keeping the team engaged so that it becomes an automatic way of life, particularly in today's environment when many facilities are challenged with staffing needs, where many facilities are challenged with overcoming communication barriers from residents with different cultures or disabilities. We need to look at the challenge of resources. Where is all of this going to come from? Where are we going to get the time? Where are we going to get the support? Where are we going to get the money? Where are we going to get the supplies that we need in an effort to do this? So let's pretend for just a minute that we've got all of the resources that we need. The next barrier that we have to explore is the availability and the accessibility of those resources to staff across each department and across all shifts. How easy is it for somebody to go and find that meaningful activity on a night shift when a resident is having difficulty sleeping? I want to go to the next slide because I wanted to share with you from the State Operations Manual a note that CMS has given to surveyors, because I think it's an important concept for us. And they say that surveyors need to be aware that some facilities may take a non-traditional approach to activities. That's another way of saying there's not one way to do this. There are multiple approaches and interventions. They go on to say in nursing facilities where culture change philosophy has been adopted, all staff may be trained as nursing aides or universal workers. But multiple duties outside of their primary role may be responsible and provide activities. So again, what we're really doing is moving more into a home-like approach and environment. Think about your own home. We do activities all day long, even when we're at work. There are activities that we engage in. And in our own home, multiple people assist with that. Multiple people are involved. And we create that sense of freedom of choice. And we create that sense of engagement and participation. The same rights need to be extended to our nursing facility residents. So they go on to say, and I put this in bold, the provision of activities should not be confined to a department, but rather may involve all staff interacting with the residents. As we examined the new blended survey process that was implemented this past November 28th, it is a focus because a large part of that process, from the minute the surveyors walk in that building, includes observation and interviews with residents and with their family members. And in every one of those interviews, there is opportunity across multiple questions to ask the resident and the representative their perspective on the value, the involvement, and the meaningfulness of activities throughout the day. So let's take just a few minutes and talk about the 6 steps in providing meaningful activities. That's moving to the next slide. So these are basics. These are things that you and I have known for a long time. The opportunity is how to expand it so that we can be efficient and we can come up with an environment that meets the residents' needs and an environment that supports and minimizes negative adverse outcomes for the residents. So we're going to look at each one of these steps, and if we go to the slide that talks about step 1, it's resident assessment. Now, we can talk about resident assessment for hours, but what this really means is some form of methodology, and it can be done by different people, different departments, that really gets to know the resident, that understands what the resident or the representative's goals and expectations are, first of all, for that admission, or if they're going to continue to live in that facility, what is going to be important for you? Excuse me. Part of that assessment must look at the resident as a whole person. So meaning that we from different departments, we from different disciplines will have input, and we may see things or hear things a little bit differently as we go about using our own individual assessments. But we really want to see this resident for who they are. Who are they from a functional perspective? How much help do they need? What can they do that is independent? Looking at their cognitive abilities, looking at things such as behavioral, looking at their medical needs. I may be somebody with chronic COPD, and that's going to have, that pulmonary disease is going to have an impact on my physical ability to participate. We want to look at the history of this resident. What have they been doing? What is important to them? What are their values? What are their preferences? So really getting to know who this resident is. It's not just a resident with a specific diagnosis. It's not just a resident who is coming to your building for physical rehab following a hip replacement. This resident brings their life history, and we have to take time to get to know what is important to that resident. Without doing this first step, we cannot go to step 2, because as we move to the next slide, step 2 talks about we need to develop a plan. Now, you've heard me talk about doing this assessment and getting to know the resident. As part of that, we need to find out, first of all, what is really important. What has worked in the past? What do you enjoy? What do you not enjoy? And at that point, we can begin to develop a plan that is done in collaboration with both that resident and that resident's representative. We talked a few minutes ago about the importance of involving other team members, and I can't emphasize that enough. Okay, activities have such a vital role. Meaningful activities, effective activities, effective resident engagement can have a positive outcome on many of the clinical issues that are often the reason that the resident is in the facility to begin with. Such things may include behaviors, pain management, depression, weight loss, and certainly over the past few years, there's been strong evidence to support that meaningful activities can often reduce the use of unnecessary medications. Now, as we begin to develop this plan that is now going to be focused on this resident and looking at how activities can be an integral part of this resident's overall plan of care, not just a piece of paper that says the resident will participate in 2 to 4 activities of choice a week, but looking at how engagement of this resident through meaningful activities can have an impact on this resident's life and multiple areas of care and concern. We then have to stop for just a moment and think, what are the resources that we need? Now, we can have residents who can dream, and we hope that they're dreaming. The regulations talk about the nursing facility's responsibility for accommodation of need. And I want to caution you that it requires us to make reasonable accommodation of need in an effort to support meaningful and engagement of our residents. So let me give you an example of that. I come to you, I've had a hip repair, I'm coming in primarily for therapy, and you are interviewing me for my preferences, and I am talking to you about my life history, and I have so excited because I've been able to retire and I play 18 holes of golf a day, and that's really my life. We don't expect the nursing home to go out and build an 18-hole golf course. But there are lots of other opportunities, such as magazines, such as videos, such as TV, such as a small putt-putt, taking residents out to a golf course and just simply involving them for a few minutes, going to a driving range, or creating something that's very small within your own community. Lots of opportunities in which we can stimulate both activity and conversation in a topic that would be important to that resident. Let's look at step 3. So we have now developed a plan. Step 3 is just as important as step 1 and 2. Step 3 is all about communication of that plan. First of all, to the resident and their representative. Let's validate that this is what you want. Let's validate that this will meet your expectations. Let's talk about how this plan can help you meet your goals. It's also important that we communicate that to the rest of our team and other members, such as volunteers, that might be involved. And not just communicate what to do, but communicate how and why. Why is this important? Where can they get the resources that they need to stimulate or to quickly provide this resident with a meaningful activity when the resident chooses or when the facility staff believe that a meaningful activity can be used to redirect or to assist the resident in achieving a different level of comfort or satisfaction. We cannot take for granted that just because we write something on a care plan, that every team member involved in the care of this resident understands where those resources are, or the methodologies that should be used, or even how to approach. So we want to take the time to educate those folks that may become involved so that we can provide a sense of continuity and a sense of consistency. Let's look at step 4. So now we've assessed the resident, we've developed a plan, we've communicated that this is what the resident's goals are, and communicated this is what we as a facility, as a team, have committed to do in an effort to assist the resident in having a positive outcome and meeting their goals. So now we actually have to make that plan work. We actually have to implement it. And that means that we're going to have to be able to provide appropriate support and resources. Again, not just limited to activities and volunteers, because quite frankly, many of the biggest needs for meaningful activities come on late shifts, late evening, and the night shift, when we have the least amount of resources available. So it seems a little odd that when we have the least amount of resources available, that may also equate to the time that those greatest resources are needed. So we have to look at how can we achieve that, because the answer is not always achieved by adding more staff. So where can I go to get those? How easily is it accessible? Does staff know how to utilize them? Do they know how to connect this for this resident? Do they know what is really important? We want to be able to identify what assistance is needed by the resident, and we also want to take credit and look at the fact that oftentimes our residents can self-initiate some of these activities that are meaningful to them if we provide them access to them. So now let's take a moment and look at step 5. We need to step back and we need to evaluate whether or not the plan was effective. And when we evaluate whether or not it was effective, we need to evaluate it from several different perspectives. From the resident's perspective, were your goals met? Was it meaningful to you? Did it help? We need to look at it from staff's perspective and from a clinical perspective. Were positive outcomes achieved? Were you able to carry the plan out? And if we're not able to do that, then we need to go back and modify and have discussion again with the resident and with the team members. So let's quickly look at step 6, because oftentimes step 6 is where we find ourselves in the biggest difficulty. Step 6 is all about documentation. And one of the things that I've learned over many, many years of working with long-term care facilities is that we do not do a good job of telling the story. We do not do a good job of giving ourselves credit. When we talk about telling the story, it not only includes documenting your assessment, putting the plan down on paper, and documenting that you sat down and discussed it. What we really want to do is to tell the story about how this plan is different for this resident than any other resident. How did we get to know this resident? How did we come to this decision? Why did we not do this? So one of the general things that have changed with all of these new regulations is an expectation that we not only do our assessments and have accurate documentation of what we did and didn't do, but that we take the time to document your critical thinking, that we document the rationale for how we came to this decision of why we do this and why we do not do that. So we want to do a couple of double checks. And I want to give you a couple of challenges. The first challenge I want you to do is to think about, is this plan unique and person-centered for this resident? What I would really like for you to do is to go back to your facility and randomly pull or have someone pull for you 3 plans of care, whether they be healthcare care plans or whether they be assisted living ISPs or whatever you may call them. And I want you to read that plan of care for that resident. And then I want you to sit back and I want you to compare each one that you've read. What is unique? What is different? So when we begin to see the same repetitive interventions, the same goals, then we probably have opportunity for making it more person-centered care. The second thing that I want you to do as you are reading that plan of care is to see how activities and the provision of meaningful activities are integrated throughout the plan of care. Not just a plan of care that talks about the recreational needs, but how can meaningful resident engagement have a positive outcome in many other areas of care and concern. Because as we go to the next slide, we're going to compare and talk for just a few minutes about some possible negative consequences that occur when we do not provide meaningful activities. I'm not saying we're not providing activities per schedule. I'm saying the activities that we're providing, the approach, the methodology, etc., are not meaningful to that particular resident. So we're going to first talk about negative outcomes that are often seen by the resident. Behaviors that create risk to that particular resident or to others. Would others be other residents, staff members, visitors, etc.? Look for negative psychosocial impact. Residents are showing signs and symptoms of depression. They're staying in their rooms with self-imposed isolation, for example. Another negative consequence could be a continued clinical decline or simply a lack of improvement. We think about this particularly in clinical arenas for pain, weight loss, etc. I want you to consider that when meaningful activities and resident engagement can be used to reduce unnecessary medications, that has a significant impact in reducing the resident's potential for adverse side effects, such as lethargy, such as constipation, etc. And last but not least, when these things fail, that tends to create those opportunities in which we have to send our residents to the ER or have them rehospitalized. And in a recent survey insert letter, CMS discussed the impact of ER visits and rehospitalization, and have created a focus that this is something that they are going to be looking at very closely, because they believe that we are discharging too many residents back to the ER or to the hospital, and that many of those are unnecessary and could have been avoided if we had provided not just appropriate care, but also meaningful activities. There are some possible negative consequences on the next slide that are impacting the facility. Certainly resident and resident representative satisfaction. Not just satisfaction regarding care, but satisfaction in general about life at that facility. Meaningful activities for the residents, when they are not provided, also tend to create team frustration, because now we are beginning to feel a sense of or question our self-worth. We're questioning why we can't help this resident. We're getting frustrated with those adverse outcomes, such as behaviors for the resident. So team frustration, staff engagement, staff satisfaction. And certainly last but not least is the fact that we know that this is a focus of CMS, and it can result in a survey deficiency. So the last slide that I have is I just want to point you in the direction of the new tools for the blended survey processes. There is a pathway to assist surveyors in determining whether or not you have deficient practices in terms of meeting the activity and resident engagement needs of your residents. So what I'd like to do is turn it over to Megan so that Megan can talk a little bit about the variety of ways in which existing technology can help you as a facility and as individual participants meet the expectations and provide more resident engagement. So Megan?
Thank you, Mary. We know that technology can help providers really evaluate how well they're doing under the rules of participation when it comes to care. But are we doing our best? A recent CDC report actually found that meaningful engagement only takes up 11 minutes a day per resident in senior care communities. So we really need to be asking ourselves, what are we doing beyond those 3 B's of Bible, bingo, and birthdays when it comes to meaningful engagement? And also, how are we focusing on those who need the most engagement? It's not hard to see why senior care communities are currently struggling when it comes to getting those numbers up for providing meaningful engagement. We're facing staffing shortages, a lack of family involvement, an increasing number of older adults experiencing varying levels of Alzheimer's disease and related dementias. Taken together, all 3 of these things can lead to an increased reliance on and use of unnecessary and sometimes even harmful medications. We know there are challenges around engagement. So how are we improving and creating a process that doesn't rely on paper-based strategies as they are currently used today? Rather than using paper-based evaluation for refinement of our activities, we can use a digital dashboard so that staff can track in real time changes in resident needs and preferences. Purposeful living then becomes a reality for each resident because we're prescribing engagement by effectively using different types of innovative technologies. Technology is supporting the engagement process by digitizing evidence-based activities, which you see on the left on this slide, and also simultaneously tracking on the right-hand side here through a dashboard who is using what program, how often they're using it, and how effective that strategy might be over time. Non-pharmacological digital strategies are safe, they are cost-effective, and they're addressing the individualized needs and interests of each resident, regardless of their current stage of living with Alzheimer's disease and related dementias. What does this mean for the community's bottom line? It means you're saving money by reducing those unnecessary drugs, reducing unnecessary rehospitalizations, also lowering the chances of costly falls, and decreasing your compliance risks. As we know, all of this adds up. Engaging with older adults is extremely important. When it's done properly, it can serve a tremendous and positive impact on the health and well-being of these residents. And with technology, we can precisely measure this impact and also then improve our strategies for meaningful engagement. Because all of these investments in engagement help everyone, both the community and the resident, we've been able to show through case studies how effective, meaningful, digitized, and individualized engagement can be, whether that's increasing staff efficiency, reducing the use of antipsychotic medication, or creating lead conversions for businesses. Our particular case study on the decrease of antipsychotics, the center circle there from Kendall on Hudson, was actually presented last year at the National Leading Age Conference. Because we have limited time today, I'd like to jump right into the Q&A section of our presentation and give folks the opportunity to ask Mary or myself questions about what we've presented on today.
Thank you, Megan. So thanks again, everybody, for listening in. We did have a couple questions come in throughout the presentation on both what Mary had covered, as well as a couple Link Senior specific questions. So I'll start with the first one that I will give to Mary here, as I believe it has to do with what she had covered. So the question is, Mary, can you just talk a little bit about the baseline care plans or the regulations? The regulations do not list activities, but CMS Critical Pathway lists activities and baseline care plans and documentation, and how those can be reviewed for surveyors to evaluate.
Sure, I'll be glad to do that. Thank you. And that is a great question. I think that when we look at the regulatory requirements for the baseline care plan, it talks about creating a plan of care that is, again, focused on the resident. It does have some specific areas, but it meets the most basic needs for that new admission at that point. I don't think that there was ever any intent to not include activities. And I think that as we look at how meaningful activities can assist our residents in meeting many of their acute needs as they are new admissions, is an opportunity for activities to be involved from day one. What can activities do to help reduce my pain? Are there meaningful activities that I can use for relaxation? What can meaningful activities do to reduce or to improve my sense of comfort within a new environment? So creating those overall approaches in terms of resident engagement and looking at how we as a team and exploring activity involvement beyond recreational needs for our resident, I think, is a key component for this. When we look at what the surveyors are going to look at, certainly the clinical pathway that I referred you to for activities is very focused. But as we look at the resident and the family interview process, you will find that a lot of this is based upon individual resident perception about the meaningfulness of the activities that are provided. Not just the variety, but are the activities that are provided something that are meaningful to you? So I think we're looking at an expansion of the word activities, and we're looking more toward the new verbiage of resident engagement and resident participation, and looking at the concept that it is much more than a singular department.
Awesome. Thank you, Mary. And we have one other question here. I know we're up against the clock here. So we did have somebody ask why or how does Link Senior fit into this entire component? And I know that at the end we went through Link Senior a little bit quick, wanted to make sure everybody got out on time, but basically Link Senior is a digital recreational therapeutic platform that provides, as Megan mentioned, both front-end, person-centered, and evidence-based programs and content to engage your residents based on their interests and cognitive levels and needs. And then on the back end tracks this, as Mary talked about a number of times, the ability not only to engage your residents in a person-centered means, but also be able to track and evaluate it. Make sure you're doing the right thing for the right residents at the right time. And so that is kind of just a very high level kind of overview on Link Senior. As we wrap up, do want to mention that at the end of this, as I close out, everybody that attended will receive 1 hour of CEU credits. Those will be sent out via email tomorrow. Once we have all the attendees within our system, you will receive an email with your certificate. If any of you did participate in this presentation and there might be multiple of you in a room, but only one of you signed on, please email Sean O'Connell. That is me. You should have my email address and all the information. It's soconnell@linksenior.com. And just let me know all the other participants that were in the room so that we can get them certified as well. And then lastly, there is going to be a survey that pops up at the end and will also be within the follow-up email that will be sent out in about an hour. That will also allow us to monitor everybody that had joined us and make sure that we can get you the appropriate information. Lastly, we do have a presentation coming up next month, as you can see up on the screen here, on February 22nd with Dr. Robert Whittingham, who is a professor of sciences and gerontology at Western Oregon University. That is open right now on the Link Senior website, and you will also have a link to that on your follow-up email. So I want to thank everybody again for joining us. Apologize about the 2-minute delay at the beginning, but we got everything going. So enjoy the rest of your days, and hopefully you can join us next month. Cheers.
Thank you.
Thank you, Mary.